test. Some differentiated if they're doing it themselves, because you will find that some people, your staff will learn to tell you there's a patient in the waiting room with their hand on top of their head. It's an odd look, but the reason that's done is because it takes pressure off of the wires coming out of the neck. When the arm is in the dependent position, I don't know how much my arm weighs because I don't have any sense of weight of my arm, but it's pulling on those nerves. Would you agree? So if I have a space-occupying lesion like a disc or a spur, or heaven forbid a tumor, I'm pulling those nerves, dragging them across that space-occupying lesion. So patients will sometimes intuitively do this, and they have just unloaded those nerves. And that is called the Bocodi sign. You'll find out later there's something called and they feel so much better. The Bocodi sign for your purposes is you have a patient with a cervical radiculopathy and you say to the patient, would you please, I like to show them. It's just so much more efficient. Why don't you do this for me? Put your hand on top of your head like this for me, please. And they'll do that and they'll go, oh, that feels so much better. I wish I'd have known about this. That is a present Bocodi sign, positive Bocodi test. Signs are present or absent, tests are positive or negative. I'm not going to be anal about that with you guys. I will in 7. So this relieves the symptoms by taking if you imagine if I took a 10-pound kettlebell and drug my arm down and pulled on those poor wires across that honking herniated disc, that arm is going to hurt. Doing this unloads it. I told you earlier I said pain or discomfort. Why is that? Because when I started into my 8th grade level, a lot of patients will get it, but some patients, especially older patients that grew up in a different time where doctors knew all, if you tell them to eat broken glass, they will say, yes, may I have some more? And that's the era they grew up. So when you tell a patient, I want you to tell me, Haley, when I do this test to you, if you experience any increased pain, guess what? If they don't experience increased pain, but their numbness goes crazy, they may just not tell you because they are taking you literally. So I say pain or discomfort. You experience any pain or discomfort of any kind at any time, let me know and I'll stop the test immediately. Good enough? Good enough. So Bocodi sign, hand on top of the head, relieves the radicular symptomatology. The reverse Bocodi is the opposite. It makes things worse because it's for thoracic outlet syndrome. Hello, Dr. Spilker. How may I serve you?
Is that step stool available?
Step stool?
Yeah, that step aerobic step.
You mean fuzzy step?
Fuzzy step.
Fuzzy step.
It's normally in that room right there.
I don't see
If you have
it
the
up
key.
here. I'm sorry.
Why would you say too?
So anyway, reverse Bocodi with thoracic outlet syndrome, when you put the hand on top of the head, it's exactly the same position, but it gets much worse. Why? Because you're closing down that scalene space, that thoracic outlet. You're closing it down. Now you're pressing on that neurovascular bundle, and they go, Doc, I can't do that. That is the reverse Bocodi sign. So now we're going to get to where's my, it's in my pocket. This is what it looks like. Cervical compression test. We are not going to become anal about kilograms and pounds. The proper amount of pressure for the compression test and the distraction test is 7 kilograms. Now, are you going to put a little scale on top of the patient's head or a force transducer when you're testing them? Of course not. It just gives you an idea. So it's about 15 pounds of pressure. The distraction will say 14 pounds. That comes out of Netter. But really just push down hard enough to compress the joints. How it works is it closes the foramina. We start with the compression test because it is the least vigorous. If you get your answer with the compression test, you don't need to proceed. you do the compression, follow it with the distraction, because the distraction is one of those tests that relieves symptoms. Compression closes the foramina and loads the discs. Distraction unloads the discs and opens the foramina. That's all I need to know. You don't need to go into Sperling A, Sperling B, ULTTA, or any of these other provocative tests. You got your answer. You know, you're not going to get more of an answer by just hurting the patient more. Fair enough? So, compression test is our first provocative test that we like to do for herniated disc, suspected herniated disc with radiculopathy. So the way we're going to do this is we're going to have our friend Haley face that way. We're going to stand behind Haley, and I'm going to just, for convenience sake, I'm going to leave the table where it's at. Can I work on you, Haley?
Yes.
All right. You sure? You might be one of the lucky 50% that's not paralyzed. But no. So what we're going to do, you want to have the patient to where you don't have to climb up here and do it, or they're way down here and you have to, you know, if you want a long career, use the table to mechanical advantage. So I'm going to take my hands, I interlock my fingers. You will see textbooks that have one hand up here and one hand here. The reason I do it this way is because if you have one hand here and one hand here, this is my dominant hand, I tend to push that way. The way you want to compress is in this direction. You want to axially load the spine. This is a Sperling A. So we use two hands, and it just makes it easier to push straight down. You don't want the head forward, turned, back, neutral position, straight down. I'm going to show you this, and I'll show you the distraction test, and we'll practice a few. So the distraction test relieves this. Everybody likes the distraction test. The only time it's positive is if it relieves their familiar radicular symptomatology. If they do not have, at that moment, radicular symptomatology, there's no reason to do the test. There's nothing to relieve. You can test them if they don't have if they're coming into you and on their form they put neck pain and right arm pain. They say, today's a good day. I almost didn't come in because my arm doesn't hurt me today. You can do the compression test to elicit it. But if there's nothing there to relieve,
What's the point?
it makes no sense to do a test. What are you going to do? Say, did it relieve your pain? And they're going to say, Doc, aren't you listening? I just told you my arm's not hurting. So the three different ways to do this test. I'm going to show you the way probably most efficient for you. You're going to cup around their ears. Careful with these earrings. You do not want to puncture their mastoid. So you got to be mindful of that. I do it differently, but this is how most people did it at my station because it's quick and easy. You're going to cup around their ears, being mindful of that earring, and you're going to push upward with your thumbs or your thenar eminences behind the occiput, and these fingers are just kind of holding their head still. Patients like it when you put your mitts on them. You don't want to, the normal approach is when you're in 5th semester is to, do this kind of thing. You'll get over that soon, okay? Get your mitts on the patient. So hands around the ears. I'm not pushing on her lobes, puncturing her spinal cord. God forbid. And I'm just simply 14, give me a break. I'm pushing up fairly vigorously. 7 kilograms, about 14 pounds of pressure. It just gives you an idea. And you feel that pulling, don't you? That's one way to do it. The other way to do it, can I get you to lay on your back for me, please? Do me a favor, don't say to your partner or your patient, will you go supine or go prone? Your patients will go, what? Pine tree? You just say, lay on your back for me. Lay on your tummy for me. 8th grade level. They're not physicians like you are. So the other way to do this, I'm not going to do this to her because I don't like this, but it is a completely acceptable variant, and you will find this is probably the way you feel that you're doing the test most effectively. You put one hand under the occiput, If I can look, she's got such a heavy brain, I can barely lift her head up. The other hand is gonna go under her chin, and you're gonna pull this way. And it is a bit of a personal space issue. And we have to, we have to be aware. We don't know what our patient's been through. We don't know if they're claustrophobic. We don't know if they've got TMJ problems. So I don't wanna damage their TMD disc because I'm yanking on their jaw, but it's a great way to do it. It's an acceptable variation. The way I like to do it, supine, I put my hands under her occiput, like this, barely touching her, the rest of her head, and then I just kind of lean back. You feel that pulling?
Yep.
Very, very easy to do. It just takes a little bit more psychomotor goings on. I recommend to you that you do the one sitting. Second option, the jaw, because you get a really good purchase on that noggin. You're holding it from behind and from the front. So I'll show you what that looks like and then we'll practice it, okay? Here's one way. This is how I like you to do it. The compression distraction. This is the first way I showed you. This is the second way I showed you. You see how you almost got your thumb in their mouth? It's okay, it's legit. Your motives are pure, but patients might just be a little uncomfortable with that, especially if you got Dorian's hands.
Okay.
They'll go clear up to their nose. So, he's got big old mitts, right?
Mhm.
So, you just have to be aware of these things, because we aren't thinking that way, because our motives are pure. But we don't know what our patient's been thinking. And then here's the other way. This is how I like to do it. Why don't you just pick a partner, and let's do compression. I just want you to feel it. I want everybody to do it and have it done to them.